Again, welcome to the fall start, really the 2023-24 season, if you will, of AI4C, Artificial Intelligence for Clinicians, that is put on by the Data Science Office. I'm Kathy Andriol, and today we have a wonderful session by Dr. Michael Rosenthal, Artificial Intelligence in the Fight Against Pancreatic Cancer. As you know, we do every second Thursday of the month, September through May and June, and we have a wonderful slate of speakers coming. These are just the fall speakers. You'll see a variety of folks who will be talking. Remember that you can view past recordings at the link there, and Carrie Ann has put this link in the chat box. If you're interested, you can go back and look. This is, I guess, our fourth year where we've been doing these, and we have these on so that you can go back and review them. We do ask you to please fill out the survey to give us some feedback as to whether this is meeting your needs and something that you're enjoying. And so that link will also be put in the chat. As I mentioned, you can watch these links anytime. Go to our Mass General Brigham Data Science Office and see some of the other educational activities and our lecture series. You can follow us on LinkedIn and Twitter as well. So now it is my pleasure to introduce Dr. Michael Rosenthal, whom I've known since he was a resident. He received his MD and PhD from the University of North Carolina at Chapel Hill, though as a Duke alum, I don't hold that against him. He did his radiology residency at Brigham and Women's Hospital, and he followed that with a fellowship in cancer imaging at the Dana-Farber Cancer Institute. His doctoral work was in computer science, where he focused on machine learning techniques for medical image analysis. Currently, he's an assistant professor of radiology at Harvard Medical School and Brigham and Women's Hospital, and he's a senior physician at the Dana-Farber Cancer Institute, and he's part of the Pancreas and Biliary Tumor Center, and he's also a fellow of the Society of Abdominal Radiology. His clinical work focuses on imaging of gastrointestinal cancers, most notably, and his passion is studying pancreatic cancer. His current research activities are using artificial intelligence to improve early detection of pancreatic cancer. And he was one of the first really researchers that we engaged when we were the Center for Clinical Data Science back in 2017, I guess now, Michael. But his group has developed methods for automatically measuring body fat and mass from routine CT scans. And he's shown that these are really biomarkers of early predictors of pancreatic cancer. His team is developing methods to screen individuals for increased risk of pancreatic cancer. He's using artificial intelligence of not only imaging, but electronic medical record data, and developing these biomarkers using multimodal techniques. We're thrilled today to have him to give us an update on his huge body of work already, using artificial intelligence in the fight against pancreatic cancer. So Michael, I'm gonna stop sharing here and give the podium over to you.
Thank you so much, Kathy, and thank you everyone for joining today. I'm really honored to have the opportunity to speak to you all. So I will be talking about artificial intelligence in the fight against pancreatic cancer, and this is a very important fight. Pancreatic cancer is an insidious disease, but artificial intelligence techniques are offering the first real insights and hopes that we've had for some time about actually being able to find these early. So I'm going to talk about a little bit of a sweep across pancreatic cancer early detection and prognosis here. Brief disclosures, I'm a consultant for Merck on an unrelated issue, and I have research funding from foundations and NCI. So pancreatic cancer screening. Right now, pancreatic ductal adenocarcinoma, which is the most common and most aggressive form of malignancies in the pancreas, represents only about 3% of US cancers, but 7% of US cancer deaths. So it's a very aggressive and lethal cancer. About 80 to 85% of people who have pancreatic cancer present at an advanced stage where they cannot be surgically resected. And their median overall survival is less than 12 months from diagnosis, which is terrible for any cancer. There is no effective screening program that exists in the general population. There are, however, groups of people who are at high risk, and this is an area in which we've focused many of our early detection efforts. In the general population, the annual incidence is about 13 per 100,000. It varies depending on where you live and some of your demographic features. There's some variability around the world. But that idea of about 1 in 10,000 among older adults is a reasonable approximation. Familial risk is defined as having 2 or more first-degree relatives or 3 or more first and second-degree relatives with pancreatic cancer. And depending upon that clustering, that can confer 5 to 30-fold increased risk. There are also additional genetic and clinical risk factors that can further elevate risk. Overall, people in these highest risk groups end up at about 100-fold enrichment when you take all of their factors together. And so you talk about in the range of 0.5 to 1 to 1.5 per 100 risk of having new pancreatic cancer each year in this high-risk cohort. So it's pretty intense. Under current NCCN and CAPS 2020 guidelines, these individuals are recommended to have annual screening with MRI and/or endoscopic ultrasound, and practically we often alternate every other year going between MRI and EUS because they seem to have some complementary features. So that's what we do now. This is really important. So the CAP study that was published in 2018 found that among people who had screening detected resectable cancers, they had a 3-year overall survival of 85%. And that's compared to less than 12-month median survival in the general population of clinically identified cancers. So if you can find one of these cancers on screening when it's resectable, they do so much better than they would in other circumstances. And this makes this kind of approach really invaluable. However, another analysis from the international CAPS that was published last year showed that this method only detects about 25% of the incident cancers, meaning if you look at 1 year of people on this annual screening protocol, only about a quarter of them are detected at an early stage. And that is really beneficial for the 25% of people who have those cancers that are found, but we can do better for those other 75%, and we want to do better. And there's an urgent need for us to find new ways to do it. We also need to do screening in the average risk population, but because it's relatively uncommon, only 1 in 10,000, it's harder to get at a cost-effective approach to do this. So this is where pancreatic cancer deviates from things like breast imaging for breast cancer and colon cancer. It looks as though in pancreatic cancer, imaging every year isn't enough. We don't actually see the masses. It's not like colon cancer, where if you do a colonoscopy every 10 years and remove all the polyps, you actually do pretty well and you have another 10 years before you develop an invasive cancer. These pancreatic cancers can go from not visible to unresectable in less than a year, and sometimes in less than 6 months. And that means we need to do something different than just find the mass. We need to find the fingerprints before the mass is there. So we think that AI is going to have a variety of impacts across the spectrum of care for pancreatic cancer. One is in computer-aided detection and classification, and this is finding the mass that is already visible when it could be seen by someone, but maybe their attention wavers, or not expecting to look there, or it's hard to see. This automated marking of suspicious areas has been around in breast imaging since the late 90s, before we had digital imaging, and has been very effective. This is also going to be important for risk stratification for treatment allocation and such. There are going to be new risk biomarkers, and I'm going to talk about several of these today, including organ radiomics, where we do mathematical analysis of organs to try to risk stratify people, muscle wasting, which has been a novel contribution from our group, and then broadly this field of opportunistic screening, where we're looking at studies that are performed for other reasons and trying to identify features that are red flags to us. AI is bringing us new high-risk screening groups. And so in particular, we're looking at what we call multifactorial risk assessments. So right now, the best clinical models that include age, sex, race, presence of diabetes, et cetera, can only get to an area under the curve of about 0.68, which is not good enough for average risk intensification. But I'll talk about a series of new risk markers that we've been developing using EMR data, using imaging data, using natural language processing that might allow us to really enrich risk in these populations and identify people from the average risk group that actually are intense enough risk to warrant screening. In particular, I'll talk about NLP-based symptom detection, also ICD code trajectories. And finally, I think AI is going to be important in treatment allocation, doing analysis of things like vascular margins and metastatic risk. And while we have programs ongoing in that, I'm not going to talk about it because there's too much other stuff to talk about today. So I'm going to begin with the story of muscle, fat, and pancreatic cancer, because this is how I got involved in all of this, and it's been pretty amazing. So back in 2014, Brian Wolpin, who's the head of GI oncology at Dana-Farber now, was doing an analysis of blood samples from some of the Harvard Health cohorts, including the Nurses Health Study, of blood samples that were taken prior to diagnosis in people who went on to develop pancreatic cancer. So they get blood samples every 2 years, they get some data every 2 years. And if you look at the people who went on to develop pancreatic cancer and compared them versus samples for those who did not, you can identify that branched chain amino acids, isoleucine and leucine, are enriched in this population. And this was not really what people were looking for. They thought maybe there's going to be some strange circulating biomarker, but branched chain amino acids were the signal that came out. In mouse models of pancreatic cancer, they found that indeed, yes, branched chain amino acids were elevated. You can see here these KPC knockout mice had elevated levels of branched chain amino acids. They predictably developed pancreatic cancer compared to control mice. And using radiotracer studies, they found that this seemed to be related to muscle breakdown. Okay, so now we have mice that go on to develop pancreatic cancer seem to have muscle breakdown as a driver of these branched chain amino acids. Again, not really the story you would expect as a circulating biomarker for pancreatic cancer, but that led us to do other studies trying to understand the mechanisms of this. And this is where I got involved with this research group. So in this particular study, which was published in Nature in 2018, we used KPC mouse models again, these mice that predictably go on to develop pancreatic cancer, and looked at tissue wasting over time. And what we found was that in control mice that have this very predictable growth curve, things went as expected. But in the KPC knockout mice, as early as 6 weeks of age, we already start to see divergence in adipose tissues, then in skeletal muscle tissues. And that divergence begins to happen before the pancreas changes in size relative to controls. So this seems to be an early marker that precedes the development of a clinically detected mass in these mice. And in trying to understand what was contributing here, one of the things that became apparent was that fecal protease activity, which is, so one of the functions of the pancreas is to produce fecal proteases. Proteases break down proteins so that you can absorb them. It's a necessary part of your survival to be able to absorb protein. And so by looking at fecal protease activity, we got a measure of pancreatic exocrine function, and that was suppressed in these KPC mice. There was also an increase in fecal protein, so you expect these to go in opposite directions, and so less protease means more residual protein, and so yes, these fit together. If you supplement these mice with pancreatic enzymes, it normalizes most of this effect. And so it does look like exocrine insufficiency is at least one of the key mechanisms causing tissue wasting in these mice. Well, that's all good for it to happen in mice. Does it happen in humans? Well, we've been working on that process for some time now. So in that particular study, we looked at a set of humans at diagnosis, and we asked what has happened to their muscle. And what we found was that about 2/3 of these people had sarcopenia, which means low muscle mass as measured by CT. And I did those CT measurements. It took me about 2 years to label all of these CTs by hand. And we do it with a standard methodology where we identify the third lumbar vertebral body. We outline the muscle and fat compartments. And we importantly found that 2/3 of these people had muscle wasting at the time of diagnosis. Now, in the general population, muscle wasting isn't that prevalent, but certainly in this population it is. Interestingly, it wasn't that people were cachectic, so they weren't skinny waisted with low muscle. Many of them were obese with low muscle. So if we look at the proportion who were both obese and low in muscle, it was more than a third of all the individuals. And this was really significant because if you're thinking about the classic appearance of a patient who's cachectic with cancer, who's thin and wasted, that's not what was happening here. A lot of the people were overweight, which is a risk factor for pancreatic cancer. It increases your risk by about a factor of 1.4, but had already lost their muscle and you couldn't see it. So this points to the idea that we actually need to measure muscle specifically to be able to find this signal. And so we looked at a group of people who were undergoing treatment for advanced pancreatic cancer. This paper was published in 2019 in Cancer Biomarkers. And what we found was that during treatment, if people continued to lose muscle during treatment, that they did much worse. They had much lower median survival compared to those who lost less muscle. So this is the quartile with the least tissue loss. This is the quartile with the most tissue loss, the muscle loss in particular. And being in that quartile with highest loss was associated with about a 2-fold increased hazard ratio for overall survival. So losing muscle during treatment is a really bad sign, and this continues to point to the significance of muscle as a marker of disease in pancreatic cancer. So having spent enough time doing outlining, I reached out to Kathy and friends at the Center for Clinical Data Science back in 2017, and we talked about building this. And mercifully, Chris Bridge and crew back then were able to build this absolutely magnificent model. Now, I wasn't alone in this. Florian Fintelman from MGH Radiology was also involved and was working towards a similar goal. And we worked together to first produce this model. It's a pretty cool model. It remains the best performing body composition model in the world, to the best of my knowledge. It takes a series of abdominal CT scans, looks at each image, and for that image estimates how far head to toe that image is from the third lumbar vertebral body, which is the gold standard. Within fit a zero crossing to that, choose that as L3, pass that slice into a unit-based segmentation network, and it produces labels of muscle, subcutaneous fat, and visceral fat. Here you can see the comparison of fully radiologist labeled ground truth area versus fully AI slice selected and labeled predicted area for subcutaneous fat, visceral fat, and muscle. And as you can see, these are really tight correlations. The R values were 0.99 for all 3 of them, just a few little outliers. So we did a formal comparison of 2 human readers versus the algorithm to see if you could tell the difference between the AI and people. I'm using something called a 2 one-sided tests of significance. And we were able to show that indeed the AI measurements are formally equivalent statistically to human performance on this task for both slice selection and for areas. So this has given us the leeway to do really big analyses because you're not dependent on me sitting there and toiling away doing labeling anymore. And so I worked with one of my residents at the time, Kirti Magudia, and again with CCDS to identify a large population of healthy-ish people that we could analyze to produce a reference cohort. And so we identified everyone who had an outpatient CT in the MGB system in the year 2012. We removed all the people who had a cancer or major cardiovascular diagnosis code in the 5 years before to 6 months after that scan. And we ran our body composition analysis on them. And what we found was that there are really important differences across age and sex and self-reported race in these body composition parameters. And so each of these lovely rainbow curves represents a population distribution. The black line is the median value, the 50th percentile, and we can go out to 97th percentile and down to 3rd percentile in red and blue, respectively. What this allows us to do is to say, for this person's set of peers, how extreme are their muscle values? You know, if you have a person who is down here, they're more likely to be muscle wasted than a person who is up here. Now, without knowing change over time, you can't know that for sure, but it still is suggestive. And in particular, if you have a cross-sectional cohort of people, you can look at their distribution and say, does it look like this reference population? And if it should look like this reference population, it doesn't, then you know that something has happened to their muscle. So this was really important because it showed us that there are important variations across these groups, that using linear corrections probably isn't the right thing to do for age. So as you can see that as we age, our visceral fat area goes up, but then it starts to fall again. So if you're dealing with a cohort that spans, say, from 50 to 80, doing a linear correction across this is going to not put you in the right parameterization, and you may, in fact, eliminate effects that are actually present in your data just by doing that. So from here, we can calculate Z-scores, and that's been important for us. So moving on to the clinical impact of this. Does body composition predict pancreatic cancer? So we've recently published a retrospective case control of 900 pancreatic cancer cases and 2,400 matched controls from Dana-Farber MGB and Kaiser Permanente in California. We performed automated body composition analysis of incidentally taken CT scans that were acquired 6 months to 5 years before diagnosis that were not known to contain any evidence of pancreatic cancer. The way this cohort was structured was that for each pancreatic cancer case, we looked back in time. For any scans they had 6 months to 5 years before, we chose 1 scan per patient. So this isn't a within patient time series. It's a set of temporal cross-sectional cohorts. And we eliminated any of these scans that were related to a pancreatic cancer diagnosis. So if you had an imaging study that showed a mass and you didn't do anything about it for 6 months, then that scan wasn't allowed to be included in the study. We then matched healthy controls based on an age band, sex, self-reported race, care center, year of scan, and use of IV contrast. These were reasonably well matched, as you can see here. Important factors here: body mass index higher than average, which is expected in the cases, so 29 in the cases, 28 and 0.7 in the controls. The indications for CT imaging were the kinds of things that people come into the emergency room for: GI system conditions, systemic symptoms, pain, new onset diabetes was a pretty rare indication. That's one of the risk factors for pancreatic cancer. So this looks like the mix of people that come in and get CT scans. It doesn't specifically point to pancreatic cancer. So we put this through our automated body composition analysis. We calculated muscle and adipose tissue Z-scores or percentiles using our index population. And what we found was that in the pancreatic cancer cases, there is a progressive decline in muscle percentile over the years preceding diagnosis. So in this chart, you can see this is the band of 36 to 60 months before diagnosis. Muscle percentile was above average. The median in this cohort was at the 60th percentile for our reference population. And as we march forward in time to 18 to 16 months, 18 to 36 months, 6 to 18 months, 2 to 6 months, and then finally to diagnosis, there's a progressive decline that happens in muscle percentile. Importantly, in the matched controls, this didn't happen. They stayed basically level over time, which is what we would expect. We also looked at BMI, subcutaneous fat area, visceral adipose area, and while all of these began to decline in that 2 to 6 month window before diagnosis, it was really muscle that extended the most had the greatest lead time for the diagnosis, and that looks like it could actually be a risk signal for early development of pancreatic cancer. Now, there are some things that we need to, well, let me talk about how prevalent these changes were in the cases. So looking across all of these tissues, 70% had loss of visceral adipose, 74% had loss of subcutaneous adipose, and 78% had loss of muscle area in their pre-diagnosis scan compared to their at-diagnosis scan. So this is a change over time. And so most of the people who developed cancer were actually wasting. There were some who had increases, and we don't have a good explanation for that yet, but people change. One of the key questions was, is this only detecting really advanced disease? Are these just the people who have METs who are wasting? And the answer is unequivocally no. There is no difference between people without METs at diagnosis and people with METs at diagnosis in terms of the degree of change between the pre-diagnostic imaging and the at-diagnosis imaging. And this is critical because if you're going to do screening, you only want to screen if you're going to actually have an actionable finding. And it's those non-metastatic cases that are the actionable findings. There were important differences between men and women. These are the kinds of things that we need to understand and incorporate into risk models. But overall, it looks like this is a real signal. So one of the key things we're working on now is asking the question of, in the general population, how much change is normal? So if you want to identify the people who are declining in a way that's predictive of pancreatic cancer, you need to know how much people can decline when they don't have pancreatic cancer. And so this is an analysis that has taken us years to make progress on now, of about 5,000 patients and 7,200 exam pairs, where we looked at the change in time between these exam pairs using z-scores, because z-scores eliminate the expected age-related variation. And so in a person who's staying about the same, they should stay at about the same percentile. I should say, a person who's staying about the same relative to their cohort of peers, they should stay at about the same percentile and have zero change over time. And in fact, that's actually what we saw in our population. The median change over time in z-score is 0. And that's critically important because it suggests that we will be able to use this as a marker. It's going to be a question of how big of a change. And the two standard deviation boundary is at about 0.3 z-score units. That is pretty similar to the magnitude of the change that was important back here. And so we have to look carefully and calibrate our models to figure out how we can best leverage this to extract a risk signal. But we're looking at competing risks now and hope to have that published in the next year. So what are we doing with this data? Well, we're applying it to a population screening cohort. So we have developed a cohort I'll talk about at the end of about 1.1 million patients from MGB, for whom we have really dense clinical data, including notes and labs and imaging studies, including about 300,000 CT scans. And we have been working for, I think it's about 5 years now to actually get the CT data for this cohort. I think we're finally at that threshold of getting access to it. But that's going to allow us to look at what the diagnostic yield is in the average risk population. We'll be able to look at change over time for everyone and compare it for the non-pancreatic cancer patients versus the pancreatic cancer patients, look at the competing risks, what other, among the people who had change, what other diagnoses were happening, and finally develop a minimum significant change threshold that should trigger a red flag for pancreatic cancer. And from there, we'll look at the feasibility for clinical deployment. There are complicated ethical issues about how to deploy this clinically, and you don't want to just start calling people and say, hey, we think you might have pancreatic cancer based on a CT scan that you had for gallstones or something like that. That needs to be done thoughtfully and as part of a well-controlled infrastructure, and it's going to take a couple of years to get that all in place. All right, I'm going to move on now to muscle quality assessments. So I talked about muscle area, but for those of you who are familiar with the body composition literature, muscle quality, meaning muscle attenuation, is used a lot. And I've avoided it for years because there's a really fundamental problem with using muscle attenuation for individual inference, and that is phase of contrast. And so when we do CT scans, we give IV contrast on many of our patients, meaning we give them a radio tracer, an agent that contains most often iodine, and iodine absorbs a lot of X-rays in the energy spectrum that we use for clinical CT scans. And it allows us to do things like tell the difference between the aorta here on this part of the scan, but also as the iodinated contrast recirculates, to be able to make out features such as the liver boundary, where blood vessels are, and where tumors are, in the case of pancreatic cancer. When we measure muscle attenuation on these, we're really measuring a mixture of sarcomere, fat, fluid, and blood. And as that blood gets a lot brighter because we've given IV contrast, it changes the muscle attenuation. And that means that if you're going to make individual inferences about a patient's risk based on muscle attenuation, you've got to know about contrast, and we don't have any tools to do that now. The DICOM standard is beautiful in many ways, but it tells us absolutely zero about contrast, and is a widespread headache for us in that regard. There are many phases of contrast that we care about as radiologists, and these are 6 examples here. This is non-contrast. This is early arterial, where the arteries are quite bright. This is late arterial, where we start to see some bright enhancement at the periphery of the kidneys and some other organs. This is portal venous phase, where the liver is nice and bright now. Nephrographic phase, where contrast has moved most of the way through the kidneys, and delayed phase, where we see contrast out in the renal collecting systems. We really need to know the difference between these because, and as Maggie Pan, one of our residents, did in a fantastic analysis of about 4,000 series, muscle attenuation changes across every one of these phases of contrast. So this is a chart of all these 4,000 series where we looked at non-contrast early arterial, of which we had relatively few, late arterial, portal venous, nephrographic, and delayed. And they're all different than non-contrast. So this difference is a median of about 6.7 Hounsfield units across this. This is important because the magnitude of muscle attenuation differences that have been found to be important predictors of clinical outcomes is on the same order of magnitude. So, for example, a difference of about 6.3 Hounsfield units was the threshold for stratifying ICU survival in a recent paper. And this says that if you're going to do individual inference, you need to know about phase of contrast. So we've now extended our manual annotation out to about 6,400 series. We've now trained a DenseNet neural network to try to do this classification. It is performing reasonably well. The weighted cap is about 0.86 right now. You can see the confusion matrix here. For the most common scans like portal venous phase and non-contrast, it's doing pretty well. We have another generation that we're working on to try to sort out some of these delayed phase misclassifications, but we think we're getting close to being able to do fully automated assessment of phase of contrast. We think this is going to be important for a number of things. One is measuring muscle attenuation and providing a corrected muscle attenuation that will allow individual inference. So we're going to be applying this to our pre-diagnostic cohort and asking, is muscle attenuation an independent predictor of future PDAC? We already know area as measured by z-scores. Is muscle attenuation an independent predictor? We think it's reasonably likely that it will be because it has been in other population-based studies, but we don't know for sure yet. Second question is, does correcting for contrast status improve the diagnostic performance of that entity? And we're very excited to have that underway and to hopefully have that data within the coming months. We're also going to be using this to look at organ radiomics. So if you're familiar with organ radiomics, I'm going to talk about it a little bit, but it's basically extracting quantitative features from tissues of interest like the liver or pancreas, and those quantitative feature vectors can represent things like what's the average attenuation, what's the size of the organ, what are some shape features, what's the internal heterogeneity, texture features, etc. It's pretty reasonable to think that many of those radiomic features are going to vary by phase of contrast, and that is not something that we've ever seen quantified or managed in the literature. So I'm really excited to see how radiomic features vary with phase of contrast and what we can do to optimize that, in part because of what I'm going to talk about next. Organ radiomics have burst onto the field of pancreatic cancer imaging as a novel risk marker. So last year, there were two really exciting papers, one out of Cedars-Sinai and the other out of Mayo, looking at radiomic analysis for prediction of pancreatic cancer. This first paper by Qureshi et al. Used a retrospective case control design looking at CTs that were acquired 6 to 36 months before diagnosis and paired with at diagnosis scans. It was a small cohort. They only had 36 total cases in the whole thing. They used 22 of them for training, 14 for testing, and they had matched controls there. They did all manual segmentation of the pancreas and did a very generous radiomic feature extraction of about 4,000 features. And they then developed a binary decision model using some recursive feature elimination and a Bayes classifier. Remarkably, though, they got to 86% classification accuracy. It's a tiny study. There's so few cases, but it was statistically significant. And with this kind of accuracy in predicting pancreatic cancer, even 6 months out, it's just spectacular. And we're really excited that this is a completely novel area of risk signal. And it's not relying on detection of a mass. It's just analyzing the pancreas. So really cool information. Shortly thereafter, the folks from Mayo, including, first author was Mukherjee, but it's from Ajit Gonka's group at Mayo, published a paper in a larger series, again, retrospective case control design. Now they use CTs from 3 to 36 months with a median of 398 days, so a little over a year before diagnosis. They separated these into 110 cases for training and validation, 45 for internal testing, more like 1.5 to 2 to 1 control matching. Now, about 40% of their cases had subtle pancreatic abnormalities on radiologist review. I do worry about that group that's closer to the 3-month mark as potentially biasing this whole data set. However, after manual segmentation of the pancreas, radiomic extraction of a more modest 88 radiomic features using the PyRadiomics platform, they were able to build 4 classifiers that had spectacular performance. The area under the curve was 0.98 for the support vector machine model. And again, it's retrospective. It's got a toe into the peridiagnostic window with that 3-month component. But still, this is phenomenal. This is so much better than any of our clinical models. And if this holds out, this really could change the world of early detection of pancreatic cancer. Just to compare to humans, and this is hard, the area under the curve is 0.66 for the radiologists. So I'm really hopeful that this is a new way moving forward. So the limitation of both of these was that they use manual analysis, and manual analysis is not going to cut it if you're talking about having to analyze the 50,000 CTs a year that are done at Brigham. So automated analysis, we absolutely need. There are no publicly available methods to do this well. There are some okay methods to do this but nothing out there that's easily available. The best models in the literature achieve a DICE score of about 0.82, which is not bad. Even radiologists have poor agreement, though. I looked at one paper of multiple radiologists, and they achieved a DICE of about 0.7 for labeling the pancreas. So it tells you how problematic this is. So we developed a novel AI architecture based on the hybrid TransUNet, which uses a transformer on the encoder side of things and a UNet on the decoder side of things. We labeled about 200 scans, about 10% held aside for testing. Kashi Shakat, one of my fellows who's going to be attending in the coming months, did all of this manually. And we were able to get pretty good performance. So to show you the difference between the pancreas and the other organs, the pancreas ensemble got to about a DICE of 0.83, which is great. It's on the leading edge of the literature, whereas liver, kidney, spleen were all up in the 95%-ish range. The pancreas is just a really hard organ to label. This looks like it's pretty good. It's not good enough for me to feel comfortable rolling this out into population scale screening, but it's good enough for us to move on to looking at radiomics in an automated fashion. And so we're now able to do this in a fully automated way. So this is a couple of really uninformative graphs, but it's the way in which they were generated that's exciting. So one of my colleagues said, hey, I have this set of scans. Can you please analyze them? We really want to know if there's a radiomic feature here in the pancreas. And so we were able to go from unlabeled CT images to these graphs in 12 hours. That's really exciting. It used to take us 2 months to do this with manual annotation and everything. It's not a signal yet for detection, but it is a proof of concept that we can actually do this. And if you had this kind of platform running in the background on your PACS infrastructure, you could generate radiomic signals for every scan that was done in a feasible way. And wow, isn't that exciting? So next, we're applying this to our pre-diagnostic cohort. We have meticulously manually reviewed every one of these automated labels for this cohort. And we're getting ready to analyze the radiomic signatures to say, in our cohort, which is a much larger cohort than what's been published, is automated radiomic signature an independent predictor of pancreatic cancer? How does it relate to these other ones that we've developed, like the muscle change and muscle attenuation? Does contrast status improve diagnostic performance when we correct this in the radiomics? And of course, we look forward to doing this in our full 1.1 million screening cohort as soon as we can. So now I'm going to switch away from imaging, and I'm going to buzz through 2 areas of EMR risk analysis that we've been working on. The first one was published just a few months ago in Nature Medicine, looking at ICD code trajectories. And so the idea here was that as people are going through their lives in medical care, every time you see a doctor, it creates a fingerprint of these ICD codes that are attached to notes and billing and such. In the US, it's used a lot for billing. In other parts of the world, it's used a lot for actual clinical care. And so we partnered with Søren Brunek out of Denmark. He's a researcher that has extensive work in the Danish National Medical Record, which is every piece of information about anyone in Denmark ever who gets healthcare. It's extraordinary. They have data going back to like the 50s. Now, it's not deep data going back to the 50s, but still they have a ton of data. And we also use data from the VA from the VA medical record to do this analysis. And we viewed the ICD codes as a time series, if you will. So for each patient, every time an ICD code popped up, it created a data point linked to a time. And we can use things like transformer models to look at this time series and try to predict an outcome that we care about, like pancreatic cancer diagnosis or death. And by training these models to recognize important sequences of these events, we can create a risk signal. So take the time series, build an attention model, and optimize for prediction error. Now, there are a couple of things that are important when we think about predicting pancreatic cancer in an open cohort. One is that you have to think about when you're predicting. So if you have an ICD code from today, what we did was predict 3 months out, 6 months out, 12 months out, 36 months, and 60 months out. This is not quite a continuous function, but we made sure that it was a monotonically increasing risk, since your risk can only increase over time. Yeah. The other thing we did was create a data exclusion interval prior to diagnosis. So if you use the data all the way up to the day of diagnosis, you get polluted by all the things that are happening, like right as you're going to get a biopsy. And so if you block the events 3 months, 6 months, or 12 months before, you get a better idea of how this could actually work in the real world. This was a big cohort, 8 million in the Danish data set, 3 million in the VA data set. The trajectories were 17 months median in Denmark, 17 years median in Denmark, 8 years median in the VA system, a ton of diagnosis codes that were more than 12 months out, 480,000 in Denmark, 1.2 million in the VA data set. The things that appeared as important predictive factors in these models from Denmark and from the VA system included things like type 2 diabetes. New onset diabetes is a really important risk factor for pancreatic cancer. Jaundice, that's obviously dipping its toe into the peri-diagnostic period. Things like pancreatitis, that's a risk factor. Other forms of diabetes and weight loss, inflammatory bowel disease, etc. So these are factors, many of which are reasonably related to known factors, to known risk factors for pancreatic cancer, but not entirely. So this is the first of the really important charts. So this chart is a receiver operating characteristic curve looking at the accuracy of labeling pancreatic cases versus those who did not develop pancreatic cancer. This gold curve uses all of the data up to the date of diagnosis. It's not very interesting, but at least it provides like an upper boundary for accuracy, and its area under the curve was 0.88. But really interestingly, if you exclude the data 3, 6, and 12 months before the diagnosis, you still get performance up to like an area under the curve of 0.81. That's amazing. The best clinical prediction models we have now have an area under the curve of 0.68. So this is doing better than our best clinical models to date. And it's just doing it with ICD codes and is otherwise completely ignorant to the patient's context. And so we think this is another important and interesting risk signal that otherwise goes unused in the medical record. This one looks at prediction intervals. Predicting just 3 months out had the best performance, naturally, because you're really close to diagnosis within an area of curve under the curve of 0.93. But importantly, we still have areas of 0.91, 0.88, 0.86 at 12, 36, and 60 months before diagnosis. So this really does have some signal to it. So what are we doing now? We're applying this to our full screening cohorts at MGB. It required a lot of time for us to curate that cohort, which is why it wasn't the primary topic of this paper. But we're going to do that in our cohort. We're also going to ask, what are the competing diagnoses? What other things pop up as red flags that aren't pancreatic cancer? Because we're sure that there will be some. We're also going to apply this to a new high-risk screening, a prospective screening cohort that we're about to start enrollment on. And I'll talk a little bit about that in the last few minutes. I'm going to talk very briefly about our NLP efforts because it is a significant and interesting effort, but I don't have really interesting data on it to present to you yet. So as you may know, medical notes are really challenging as data sources. They're often free text, even under Epic, where we use templates. They're still pretty free form. You've got to identify symptoms. You have to identify negative symptoms. So this is a positive symptoms where they're talking about a history of epigastric pain and weight loss. This is a negative symptom where they're denying all of these things. But you can imagine if you just used a tokenizer and looked for vomiting, it would say, yeah, vomiting's here. But you've got to look all the way back here to know that it's a negative. And so these models have been complicated to develop. ChatGPT, GPT-4 have blown this area wide open. Still not ready for prime time on the clinical analysis front. Still making up some information that goes as it goes along. But there are new pathways such as the new GPT-4 PHI API that's coming out from Microsoft, where Microsoft is assuming the liability for not exposing PHI within these notes to the OpenAI interfaces. And it will be able to actually pass in notes that haven't been manually scrubbed to this to do feature extraction. That's when I think we're going to really get an idea about how well these large language models are going to perform in this task. In the meantime, we've been doing data annotation. I'm going to skip past this for the sake of time. We started off with a clinical BERT transformer, which is kind of a mid-size language model. We have now applied this to 87 million notes in our screening cohorts to extract symptoms and diagnoses. This transformer identifies both positive and negative mentions. So it'll say if pain is mentioned as present, it'll say if pain is mentioned as not present. It'll also tell us if nothing was mentioned at all. So it's really kind of 3 levels, or 2 with a gray middle. So this produces about 10,000 parameters per note. So talking about 87 billion data points from this set. We're now working on the time series using the same kind of modeling approach that we did with ICD code series. It is a really interesting task to figure out how to build transformers, recurrent neural networks, even Cox regression models that can handle data at this scale. But I'm hopeful in the next 3 months we're actually going to have our first risk signal out of this. So how are we? One of the important ways in which we're doing this is actually, it's not just us. We're doing this jointly with our friends at UCSF using a really interested shared data model. So what we've done is taken our 1.1 million person cohort and converted that into a common data model called OMOP. And I thank Kathy for guiding me towards trying to use a standard ontology a long time ago when I was ignorant about this. We have since gone through this conversion, which was a big deal. It cost about $500,000 in personnel time to get this done. And then we tripped over our friends at UCSF who have done the same thing. And this is amazing because they also have 1 million people in their cohort, including a bunch of people with pancreatic cancer. So what we can now do is take our models that we've developed and their models that they've developed, and using federated learning and federated deployment, where we use a secure networking layer, we push these models to the local sites. The PHI never leaves the local sites, but we can generate these extracted feature vectors, and we can then train risk models on them jointly across the sites, but in a PHI preserving way. We work with a partner that was actually spun off, at least arose from parts of CCDS, Rhino Healthcare, which has been doing a great job providing federated learning services to us. So we work with Rhino to do this, but it allows us to do site-agnostic training, site-agnostic validation, and deploying of these models to develop new pancreatic cancer risk models, but also to do things like make our NLP models work better, because there's a lot of site-specific variation in how these things are structured, and we've already seen clearly that doing site-specific adaptation is going to be important to making this work well. The cool thing about this is that when there are other sites that want to come and join us and have their OMOP repository intact or already formed, all we have to do is add them into our Rhino enclave, and you can get going. You don't have to do anything else. The lawyers don't have to get involved to the same degree because there's no data sharing. Obviously, there are other lawyerly things to be done, but we're really excited about how this has been going. And the NCI is also very engaged in this and is showing some signs that it's looking to take up federation as a potential way of managing data and data availability across its enterprise. Okay, so what are we doing now? We're applying this approach to our full screening cohorts and develop time series models, eventually moving this into our prospective screening studies. So I'm going to finish here by talking about how we're actually moving this towards the clinic. So as I mentioned, we've curated a cohort of about 1.1 million patients from MGB. This was a time-consuming process because what we wanted to do was identify people who had at least 6 months of contact in our system, and our PDR doesn't really allow us to do those kinds of contact time analyses. So we had to retrieve very gently a much larger cohort using basically just vital signs and saying who had vital signs, thinking like what's the most gentle touch we can possibly think of, and looking at everyone who had at least 6 months from their earliest to the latest vital sign. We then pulled this full cohort, all their notes, all their labs, all their imaging studies, and we've been going through the process of curating the pancreatic cancer case side of things, as well as the non-pancreatic cancer side. So we've learned some important things. One is that we had to left censor everything before 2008 in this open cohort because we couldn't find any cases. There just wasn't good diagnostic record keeping back then. If we do this left censoring at 2008, we arrive at these age-specific incidence bands, and we can compare, for example, the 25 per 100,000 at our 65 to 69-year-old band in the full cohort to what we see if we just look at post-epic go live, where the incidence is twice as high. And we can then compare that to the SEER, the national cancer incidence rate for pancreatic cancer. What we see is that post-epic go live incidence looks a lot more like SEER. There are some bands which are a little bit lower. This probably relates in part to differences in referral patterns to Dana-Farber and MGB, where younger people are a little more likely to seek tertiary care centers. But we continue to go forward. Nonetheless, it looks pretty plausible, and we're building risk models based on this now. All right, jump to there. One of the really interesting issues was that finding the cases was not easy. So in some prior publications, people have just said, oh, if there's an ICD code for pancreatic cancer, you're good to go. We found that was only about 30% accurate. And so we did two things. One was we looked at ICD code density. So we found that if you had multiple codes within a 6-month window, that it gave us the best classification accuracy. So looking at this code density, we can get an ROC of about 0.96 for the presence of pancreatic cancer. And we ended up using a cut point of about 5 ICD codes within a 6-month window as being a pretty good guide for the automation side. However, we wanted to be really sure, so we actually manually curated everyone who had an ICD code for pancreatic cancer and everyone who had at least 5 ICD codes for any other GI cancers. We've ended up finding about 18,000 GI cancers, all of them manually curated. Boy, was that a lot of work. But now we have this really rich data set of 1.1 million at-risk people and about 18,000 GI cancers that we can use for screening. So what are we going to do with that? Well, we're integrating this into a big package here. So we have a familial risk cohort. These are the people who are high risk for pancreatic cancer that I talked about, and they are already undergoing this annual MRI endoscopic ultrasound, but we're going to be doing more things for them. We're also looking at this combination of opportunistic imaging biomarkers, EMR risk, NLP, to develop multimodal risk enrichment tools so that we can identify people who are at the same 1% per year risk as the established high-risk people. And we want to put those people into enhanced screening where we do MRI endoscopic ultrasound, but we also look at things like exocrine insufficiency using fecal elastase testing that we're evaluating with our friends at the Broad Institute at MIT, who have developed a new nanosensor for this. I'm looking at new onset diabetes, multi-cancer early detection assay using DNA fragmentation, methylation, etc., organ radiomics, EMR risk, to finally move to better early detection and cure for both the high-risk cohort and for risk-enriched people in the general cohort. We are just about to open a new prospective screening protocol for high-risk people, and I'm going to talk about this in more detail, but it is going to be using some novel blood biomarkers, but in the background, we're going to be doing all of our novel biomarkers to see if we can identify a prospective risk signal. If we can, we will move this over to return of results for things like our EMR risk, our body composition risk, etc. So this has been obviously an absolutely massive effort across many people. Many thanks to people like Kathy, Florian, and Chris, who really got this ball rolling 6 years ago, but also to my very large team. I know that I've taken up the full time, but I would love to stay for questions if anyone has any.
Well, Michael, that was a tour de force and a wonderful body of work. Thank you so much. That's fantastic. I know we both have to go, but a couple of quick questions. I know you're looking at high-risk screening population. Do you see this ever moving to opportunistic screening that is on every CT that's done across MGB or elsewhere? Is there value in that, or are we just going to see lots of incidental findings that may lead to other going down a certain path? Is there value in screening the whole population for this?
So I think the answer is going to be yes. I think the question is, when do we get to yes? Yeah. Because we do critically have to answer, first of all, how you ethically do the study that shows that opportunistic screening is beneficial, because you can't consent 1 million people to participate. And so population-based consents have been used in things like trauma products where you can never predict like who's going to get into a car accident and you can't consent them preemptively. But we've got to go through that whole process with the IRB to figure it out. But I think that it looks really obvious that for cardiovascular risk, for cancer risk, they're going to be important signals here. We just need to figure out how to deploy them in a way that can be used responsibly. I contrast this with the way that multi-cancer early detection assays have been deployed, where basically they got FDA, not approval, they don't have an indication, but they're allowed to be sold now. And so people can just go and buy one of these assays and get a, like, yeah, you have cancer, no, you don't. And then they just have to go to the hospital and figure out how to manage this. That is, in my view, irresponsible. And we are developing clinics to try to manage it, but we want to do a better job with opportunistic screening on our side. Still, I think within the next year or two, there will be a definitive application that shows benefit, and that will make that data available in a broad way.
Fantastic. And then one more quick question, because I know we have to go. On the radiomics side, were there, you look for thousands of different features and only a small amount actually come to be meaningful. Were there things that are visible that, or are these all things that are not visible to the human perception that were important radiomic features?
So one of the things that I was really heartened by in those two radiomics papers was that the feature vectors that were significant included multiple measures of heterogeneity. And an entropy is not something that your eye necessarily notices. Like, you can tell the difference between TV static and a white piece of paper, but degrees of TV static don't really do that much for you, at least for those of us who have actually seen television static, which I have to stop using as an example because people have never seen that. Nonetheless, when we think about glandular dysfunction, fibrosis, metaplasia, from a biological perspective, it makes sense that heterogeneity would be something that we would be seeing, even if our eyes aren't picking it up easily. So I think that there's biological plausibility to the radiomic features. It's not like some arcane texture oriented at 45 degrees as the major driver here. No, it's like, entropy is the major risk signal. That's great. I like that, and I'm excited to see where that goes.
Fantastic. Well, Michael, thank you so much for a wonderful, wonderful talk and wonderful work on a very, very important clinical area. So thanks again, Michael. Really appreciate it.
Thank you all. And I'd love to take questions by emails if anyone has any of them.
Take care.